Hemolytic anemias are caused by increased destruction of red blood cells. There are multiple causes for hemolytic anemia. These factors can be intrinsic to the RBC, which shorten its lifespan. These include hemoglobinopathies, RBC membrane disorders, and RBC enzyme defects. Factors can also be extrinsic, which include immune-mediated destruction, non-immune mediated destruction, which can be due to toxins or certain medications. In this lecture, we will focus on RBC membrane disorders. In this lecture, we will focus on RBC membrane disorders. Normal red blood cell membrane comprises of a lipid membrane and an underlying skeleton, which is made up of proteins. The underlying skeleton is made up of proteins actin and spectrin, which is a worm-like protein made up of two chains, alpha and beta, and these two combine to form a meshwork, which is the underlying cytoskeleton. And this forms a horizontal scaffolding. This meshwork is attached to the lipid membrane with vertical associations. And these are the vertical associations. First is the enchirin complex. So enchirin complex anchors the spectrin via enchirin and protein 4.2 to band 3, which is present in the lipid bilayer. Band 3 is an anion exchanger in the lipid membrane. Second, we have the actin junctional complex, where actin binds to spectrin with the help of protein 4.1, which forms the junctional complexes, which are then tethered to the lipid membrane with the help of adenosine, which attaches it to the band 3 and other proteins in the membrane like glycophorin. Mutation in genes which encode these structural proteins cause instability of the RBC membrane cytoskeleton, making it less deformable, more prone to destruction, and hence reducing the RBC lifespan. Different types of RBC membrane disorders are hereditary spherocytosis, hereditary elliptocytosis, hereditary pyropoikilocytosis, xerocytosis, and stomatocytosis. In this lecture, we are going to discuss these first three. So, hereditary spherocytosis, it is the most common cause of RBC membrane defect. Most of the cases have autosomal dominant inheritance, and it is due to mutation in genes encoding proteins which are used in vertical associations. So it will include all the proteins in the enchirin complex. We have enchirin, spectrin, protein 4.2, and band 3. These are the genes which are involved, but we don't need to remember those. So normal RBCs are biconcave in shape. In hereditary spherocytosis, due to mutation in genes for proteins which encode for these vertical association, the membrane is not stable, so there is loss of the lipid bilayer, which decreases the surface area of the RBC relative to the cytoplasm. Which makes the RBCs less deformable and they take the shape of spheres. And these spherocytes are destroyed as they traverse the splenic sinusoids. Normal RBC lifespan is 120 days, and in hereditary spherocytosis it is reduced to 10 to 20 days. Clinical features include those common of hemolytic anemias in general. We can see neonatal jaundice due to elevated unconjugated bilirubin. There can be pigment gallstones, splenomegaly due to increased destruction of RBCs in the spleen, and mild cases of hereditary spherocytosis may present later in life. Labs will be consistent with hemolytic picture. So low hemoglobin, increased reticulocyte count, increased direct or unconjugated bilirubin, and low haptoglobin. On peripheral smear, we see spherocytes. So spherocytes are round and there will be loss of central pallor. A normal RBC has area of central pallor and there is more pigment in the periphery when we look at it in smear due to its biconcave shape. But spherocytes are round, so there's no central pallor. Diagnosis is confirmed with genetic testing. Previously, we also used osmotic fragility test. Treatment here is supportive with folic acid supplementation, as hemolysis results in need for increased RBC production. Transfusion support as needed. Some cases require cholecystectomy due to pigment gallstones, and refractory cases managed with splenectomy. Next, we have hereditary elliptocytosis, and we'll actually discuss it along with hereditary pyropoikilocytosis. So hereditary elliptocytosis. This disease is caused by weakening of the horizontal scaffold. So mutations in spectrin, which cause a qualitative defect. Some cases are also due to mutation in protein 4.1. Remember that protein 4.1 helps bind spectrin to actin. There is higher prevalence in malaria endemic regions. Likely due to a survival advantage. Clinical features, it is mostly mild, asymptomatic. People can develop episodic hemolysis in the setting of acute illness. Diagnosis is made on peripheral smear, where you'll see mainly like elliptical shaped cells. Usually it is incidentally noted. And then coming to the hereditary pyropoikilocytosis. Like hereditary elliptocytosis, this is also due to mutation in the horizontal scaffold and mutation in spectrin. Clinical features are variable, and peripheral smear in this case shows fragmented, bizarre shaped RBCs, and you can also see